So the topic is rationale and technologies. Well, I start with an announcement. This is what I think. I think that given the fact that mechanical ventilation is not a cure for the sick lung, it allows patients to survive, but does not cure the lung. That mechanical ventilation is not the best support of the respiratory function. Mechanical ventilation is dangerous for the lung and for the patient. So CO2 elimination is what dictates the need for ventilation. We ventilate to eliminate CO2. We do not ventilate to oxygenate. So when we double ventilation, it's because we are inefficient in eliminating CO2. And all our patients normally have a problem of ventilation that is a problem of eliminating CO2. Now, this is a slide from 1975, 76 by Colobov and Gattinoni, or Gattinoni and Colobov. And it shows that if we remove CO2 with an extracorporeal membrane lung, the so-called carbon dioxide membrane lung, if we remove CO2 from 0 to 100% of the produced CO2, ventilation can go down from 100% to 0. That is, if we remove 50% of CO2, we can ventilate 50%. If we remove 75% of the CO2 produced every minute, we can ventilate 25%. That's a good thing. But instead of ventilating 15 liters per minute, we can ventilate 3 liters per minute, even 0 liters per minute. And obviously, if we have no ventilation, we have no ventilator-induced lung injury. Now, CO2 removal is around. We know how to perform CO2 removal. We have devices to remove extracorporeal CO2 removal. But we can do that at high flows, 2 liters per minute or more, or at very low flows, something like hemodialysis. And there is a huge confusion and huge guessing about everything, about indications, effectiveness, risks. So let's see if we have any data and which is the rationale behind or beyond CO2 removal. We started CO2 removal in 1979 at high flows, something between 1.5 and 2 liters per minute. We started in ARDS patients. We published it in 1980 on The Lancet, and we knew exactly why we wanted to do CO2 removal, and it was to achieve this, to avoid barotrauma and the extrapulmonary derangements caused by conventional mechanical ventilation. It's written there, because we did not call it ventilator-induced lung injury, because the name was not around yet, but we knew what we wanted to achieve. Then we kept working, and some 10 years later, we tried the first low-flow CO2 removal. This was CO2 removal in a patient with bilateral bronchopleural fistulas that did not heal under mechanical ventilation. So we applied low-flow CO2 removal at 300 milliliters per minute with the pediatric membrane lung, and luckily enough, the patient survived. He went to CPAP, low pressure, spontaneous breathing, and the fistulas healed. Another 10 years, and Marco Ranieri published his study on ultra-protective ventilation. We know that 6 milliliters per kilo is better than 12. What about 4 milliliters per kilo or 3 milliliters per kilo? Because he had just shown on a paper published on the American Journal of Respiratory and Critical Care Medicine that even in ARDS, when ARDS patients are ventilated at 6 milliliters per kilo, some 30% of them get hyperinflation and high risk of ventilator-induced lung injury. So we do not really have a way to avoid ventilator-induced lung injury in all patients. Possibly we know how to recognize them, but then we do not know what to do. And one good chance is that if we decrease tidal volume, we can be ultra protective for ARDS lungs. And Marco Ranieri showed that he could bring back to normal PCO2 and to normal arterial pH those patients that could not be ventilated at 6 milliliters per kilo because of high plateau pressures by removing CO2 extracorporally with a device at low flow, less than 400 milliliters per minute. This opened up a new world, which is ultra-protective ventilation by extracorporeal CO2 removal. This is another 4 to 5 years later, Thomas Bein from Regensburg published his first clinical trial. This is an outcome trial. First, the primary endpoint was not reached, but ventilating 3 milliliters per kilo versus 6 milliliters per kilo, he could show that patients with the lowest PF ratio could be weaned earlier than patients ventilated 6 milliliters per kilo. Numbers are small, as you can see. But it starts to be a good suggestion, a good indication. Still, we do not know what to do exactly with the patient lung management during CO2 removal. It's something we still have to learn, how to preserve end expiratory lung volume, how to avoid atelectasis at very low tidal volumes. And this is the Supernova study. It's a study that has been designed by Alain Combe and Marco Ranieri to assess the effect of the ultra-protective ventilation in ARDS patients. The study is right now into its pilot phase at low blood flows, and we will see what comes out. So in early or moderate ARDS, extracorporeal CO2 removal, what could it be used for besides ultra-protective ventilation? Well, I think that we could explore whether extracorporeal CO2 removal could be helpful, in some cases to prevent intubation, in many cases to extend the application of non-invasive ventilation, in ARDS, mind you. We know that in acute hypoxic or hypoxemic respiratory failure, non-invasive ventilation is not as successful as it is in COPD patients. These are data from a paper from Massimo Antonelli on non-invasive ventilation in acute respiratory failure patients. And they investigated whether they could recognize successful non-invasive patients that would be successful under non-invasive ventilation from those that would not. And actually, a few parameters were different, like oxygenation. Basal was the same, but after 1 hour, successful patients had PO2, FiO2 ratio slightly different. Respiratory rate, basal was the same, but non-intubated patient had a lower respiratory rate. But look, the significance of the respiratory rate is much higher than the difference in oxygenation. So patients that fail non-invasive ventilation, even in acute respiratory failure are those that do not decrease their respiratory rate. That is, and it's possible that these patients might benefit from CO2 removal. We don't know. We know that extracorporeal CO2 removal helps non-invasive ventilation when recovering from ARDS. It might help weaning. It might allow earlier extubation. But we do not have hard clinical data. CO2 removal is an experimental technique. See here one of those patients that are non-intubated, undergoing extracorporeal gas exchange. The other broad field of application of CO2 removal is COPD patients. And here we have data showing that extracorporeal CO2 removal helps in preventing intubation and allowing early extubation. The mechanism here is very intriguing, and it might be at work also for acute respiratory failure patients. This is a patient reported by Cardenas, and let's PPI alone. We don't care about PPI. But when CO2 removal is started, you can see that the green triangles here, are total CO2 production of the patient. Why does total CO2 production go down if we remove a small amount of CO2? Because the respiratory work decreases and the patient uses up oxygen and produces CO2 just because he's working to breathe. Because the work of breath might be 30, even 40% of the total O2 and then total CO2 production of the patient. And if we remove and if we decrease the respiratory work, the oxygen consumption and the CO2 production will go down. And that will amplify the effect of removing even a small percentage of the CO2 production. These are a paper by Kluge in patients showing that intubation can be avoided in COPD patients. But a word of caution, we still do not know how much CO2 we need to remove and at which blood flows. As an example, Marco Ranieri and Kluge reported low flows, but in this paper, as well as the papers by Abrams, they required 1 liter blood flow almost, 3/4, 0.75 liters per minute. But again, the group of Nava, Del Sorbo, and Ranieri reported a positive effect of CO2 removal at very low blood flows. So I think the problem here is defining at which stage and which kind of patients would benefit from these very low flow CO2 removal devices. So in conclusion, and I strongly insist on that, extracorporeal CO2 removal is still an experimental technique. We do not have defined protocols, defined indication, defined technology for it. The major issue in CO2 removal is that it controls ventilation, and we have to learn how to handle patients' ventilation under CO2 removal. The main risk is alveolar collapse at low tidal volume and low pressures. If we want to be successful with CO2 removal, we need efficient system that remove a lot of CO2 from a very small amount of blood, because we need simple, low invasiveness systems, something like hemodialysis. We should be able to work at low blood flows, ideally 250 milliliters per minute, in this range. So we do not care much on how efficient membranes are. We care about how much CO2 we can remove from a given amount of blood. Because what limits the CO2 removal application is the amount of blood. And we have been studying ways to increase CO2 removal from blood, and we have been studying the effect of adding acid to the blood. We've been studying the effect of adding lactic acid to blood before the membrane lung. Lactic acid converts bicarbonate to CO2, and CO2 gets out from the membrane lung very quickly. Then the animal or the patient has to metabolize the lactate. So now we are working with hydrochloric acid produced by an electrical device which is called Electro Dialysis. Basically what happens is that in blood we have a lot of chloride as sodium chloride or potassium chloride. In an electrical field, the chloride ions goes one way and the positive ions go the other way. So we can produce hydrochloric acid from the dialysate flow or from the ultrafiltrate flow. And by applying electrodialysis to the ultrafiltrate, we can produce hydrochloric acid that is useful to remove CO2 and then give back the sodium to the animal. So basically, we have an ultrafilter here which produces ultrafiltrate. The ultrafiltrate is split into an acid portion and a basic portion. The acid portion is used to remove CO2 from blood. The basic portion is given back to the animal, so we don't do anything to add or remove anything. We just remove CO2 by applying an electrical field. And by doing that, we could double the CO2 removal from the blood flow. So here, with this system, we can remove almost 200 milliliters of CO2 from half a liter of blood. And that is very efficient, doubling the efficiency of the system. And I'd like to thank my mentor, Dr. Kolobov, who started all this business of membrane lungs. Thank you very much.